Now we're going to go into the science fiction-y stuff because I was asked to talk about emerging technologies. So, important thing here is I know about some of these things, and I've done some of this, and some of it I have not done with, and I've talked to colleagues who are kind of like, I know there's one guy in Glasgow that's doing it, right? It's like one thing, right? So there's definitely things on here which are more adjacent to what we're doing in practice, and some of the things that are here, and I apologize because some of these things have names, and I could not, because there's one person who's doing a phase 1 clinical trial, and I can't not tell you. But the idea here is for you to understand that what people are working on to make the noggin work a little bit, right? To kind of see what's going out there, right? So here's emerging technologies. I have no conflicts to report for this. Again, some technologies here are still being developed and are not currently available on market, and they're reported here just to demonstrate what direction the field is going in, okay? So here's what we're going to talk about. Smart insoles. I'm sure there are people actually in this room who've worked on some of these trials. RTM, remote temperature monitoring with a smart mat. Infrared thermographic-based computer-aided diagnosis, which is basically using AI to help us when we get dumb. This is super cool. Electrospun nanofiber matrices. Definitely the direction that a lot of dressings are going. And then because it's a vascular conference, I wanted to talk about SVF injections, which are very cool. Not every, I mean, again, this is all, that's in phase 1 stuff, but it's very interesting stuff. Okay, so smart insoles. So what do we do here? So what it does is you put these in the shoe, they continuously monitor skin temperature and pressures as early indicators of injury. You basically put it in the insole and it connects to a battery, and then it goes to an app to your phone. You know, similar to like when people now, when they do like EKGs, and right, you kind of hold your phone and it sends it to your cardiologist, like almost like a Holter monitor, right? So here's how these things work. This was actually from the Lancet. Here's it goes to a smartwatch. It gets put inside the shoe, and then it tells you whether something bad's happening. And then it goes, high pressure detected, right? Warning sign. This is bad, right? Okay. So in this proof of concept, they saw that there was a 71% reduction in ulcer incidence in the group that intervened versus the group in the control, and they found that the ulcerations were the same between these two groups. The ulcerations happened more in the control group than in the intervention group, and the people who are good compliers, meaning the people who use this more than 3 days a week, they actually had better. I mean, intuitively, it actually worked better for them because they were being warned more. It doesn't say in the paper what they did when the warning sign happened, but it just said that they were warned more. So I mean, that kind of technology has been out for a little bit. But again, what does this do? It kind of syncs the patient to, one, pay attention to their body, right? It's kind of like, you know, what used to happen when we used to ask patients to check their glucose 8 times, 5 times a day when they have insulin, right? And now we have continuous glucose monitors. So you've taken a little bit of the work of where they could be making mistakes out of their hands, and now you're allowing for automation to kind of take place. So there are going to be warnings, and they're probably going to be, at some point in time, they're going to get annoyed and they're going to shut it off. But the idea here is that there's a constant flow of information about their problem areas. This is a remote temperature monitoring mat, and this is actually used in the VA nowadays. That's the only real place that's being used. And it's a mat that you stand on for 20 seconds a day, and then what it will do is it will check temperature differentials between your feet. Okay. Now, if you look on the left part, like on this part over here, this is somebody who actually did not develop a new ulcer during the length of this study when they were using the mat, and there was really no asymmetry between their 2 feet, right? So when they woke up in the morning, they put their feet down on the mat, temperature was fairly the same, didn't develop an ulcer through that timing. If you look at the other one, right, you look on the right side, here are the different, right, there's a large difference, so it's asymmetrical. When it's in this crosshatch area, there's an asymmetrical thing, and then the person developed an ulcer underneath the fifth metatarsal. This is actually the right foot, not the left foot, because of the way the projections go. Okay, so again, part of this part of this remote temperature monitoring, the outcome was to make sure that there was no development of a non-acute diabetic foot ulcer. Then they looked at, are we testing what we're supposed to be testing, right? And they had about 130 participants. They had 53 DFUs, and they found that if you have an asymmetry of a little bit above 2 degrees Celsius, it will identify at 97% of the time of an observed DFU, and a lot earlier. So that a temperature, early temperature changes can predict what's going to happen like later on, right? But it had a very high false positive rate. When you increased it to 3 degrees, the sensitivity went down because you gave it a larger parameter, but the false positives went down as well. But no matter what you did, the lead time was about 35 days of knowing that something was going to happen there. And the group that were the good responders, or the people who behaved, used it for at least 3 days a week. Okay, so that's the computer mat. So those two things are actually used in, those I would say that they're more frequently used and probably a lot earlier to market. Now we're going to start going to things which are still in production right now, right? So using computer-aided diagnoses, right? So having an AI try to help you with a problem that you may be making more mistakes. And we use this in radiology right now when they're doing breast imaging, right? They kind of do a scan and they try to highlight to the doctor, maybe you should take a look at this spot a little bit more. I started using computer-aided diagnoses now with making 3D custom orthotics, with using a gait assessment and my own assessment to kind of create something. So it's a combination, and that's kind of a very similar thing here. It's combined computer and practitioner. Bless you. Okay, so in the normal foot, right, a lot of blood vessels going. This is good circulation, and then we have bad stuff. That's kind of, this is what it looks like, right? So I do not understand how AIs work. I just wanted to get this cool picture for the people who may understand how AI works. But this is how these systems kind of get broken down if you're a computer person, right? So the idea here is to help the doctors make an accurate diagnosis. Why? Because when you're looking at images, humans, there are lots of reasons why we're prone to making mistakes. Also, some places may not have an appropriate clinician to be able to make that diagnosis. Go to urgent care and get an x-ray at 9 o'clock at night. Good luck finding out, who's going to go ahead and take a look at it, right? There's nobody here. They have somebody in Kentucky looking at it by the time they get it, right? It's like, so these things do happen. Sometimes you don't have resources. So this kind of computer-assisted diagnosis can help you overcome these kinds of things. And again, this is just an idea of, there has to be algorithms and protocols for it in place, and that's why they're not really used right now. Because, by the way, what happens when the computer makes a mistake? Whose mistake is it? Is it your mistake? Is it the computer's mistake? Is it the company who makes the computer's mistake? Right? So there's definitely some sketchiness that has to be ironed out here. Okay? And this, by far, to me, is the coolest thing, right? So electrospun nanofibers, so ENFs. So the way that these fibers are made is they're made, there's a solution that kind of gets injected through a battery, basically, right? That creates a current, and then there are these rolling fibers that kind of happen, and it's kind of like this roller board, and what happens is it gets spun out. It's almost like cotton candy. That's the best way I can explain it. It's like cotton candy dressing, okay? And you can make these fibers ultra thin, and you can create the lattice that you want based on the different polymers that you're putting in there, because you may want to capture things. Now, it's the same thing as when we use CTPs, like cellular tissue-based products, where we have these matrices and these different lattice works, but you can actually now control how you want that lattice to be and how thin it is as well. This is one of the applications of it. It's actually like a gun that will spin out these fibers and make a dressing with it. So it's derived from polysaccharides, and it looks like the extracellular matrix. You can create a large volume for it. The other thing you can do is you can impregnate it with drugs, so the drugs can kind of get this. This is something that will definitely have a place in burn, because of how large it is and how quick it is. I'm going to show you a video in a second, and I apologize. Again, this is in phase 1 trials. There's no one else that's doing this kind of thing. I'm sure there's going to be 50 other people that are going to copy it soon, but this is something that's similar to this. So here we go. This is how that thing kind of comes on. It gets sprayed on with this gun, and then you can kind of spray, take this on and off. Again, you can also do it multiple times when you're doing dressing changes. So, and it mimics the actual skin. It has some tensile strength to it, right? Depending on what you want to build it with, which is pretty amazing in terms of like using like this is very, very different than what we're doing. Again, so here's that gun. You would just, again, kind of spray it on there. Let's say that's the wound. You now spray it on there. Again, someone has got a big burn. You would spray it on there. And again, it comes up. It's like shooting cotton candy, except it's a matrix. Okay. Again, I've never seen this in utilization. So, but this is kind of how it works. All right. Let's do the next. Can we go to the next slide? Okay, I'll just kind of play it. All right, anyhow. So this is the last of the newer technologies, and again, because it's a vascular conference, I really want to talk about it. And this is adipose-derived stromal vascular fraction injections. So adipose tissue is a very, very, very good reservoir of growth factors. It has a tremendous amount. We have a ton of it. And some of us are probably even using that, right? You can actually do fat harvest and spin it down. Some of you may have used something which is in clinical practice of doing injectable fat in certain areas. Even you can use them under ulcers or pressure points. And so again, it's using this adipose style tissue. So what's the issue here again? So DFUs have microarterial disease, and people also have peripheral neuropathy. There's also macro disease. And again, these mesenchymal cells, these stromal cells that are highly available in fat can be used to help with this, right? So stromal vascular fracture is able to induce new vessels under certain kind of conditions, right? And this will become a little more evident when I show you the pictures and the videos. It will help basically grow new blood vessels in an area of ischemia. The rate of wound healing doesn't matter whether it's a larger wound or a smaller wound, and you can put them at the terminal areas of the foot and actually will create, again, new blood vessels in that area. So here's a paper. Again, this is something that's not new, but it's definitely being developed a little bit more. You can see here preoperatively, and what they did here is they did an angiogram, and they looked at identified certain areas where you would inject these stromal vascular fraction cells that they derived from fat and put it in there. And then you could see over a period of 8 months that there's been new vascularity that has formed. I mean, look here. You don't have to be an expert in reading angiograms, but this is less, this is more, right? And right? I know there are videos in there that they're identifying, oh my God, look at this, and this vessel comes here, and I go, oh, this is more than this. Okay. But this is pretty cool. They're not doing anything else. They're doing local wound care, nothing else. It's growing new blood vessels in an area, which is fantastic. Okay, so this is on the right-hand side. You'll actually see how this study was created. But basically, what they do is they find those isolated areas, and you can inject in the area around the wound, or from these blood vessels, which actually now and again create new blood vessels in an area. Here are some examples of that. So these are examples of complete closure of these wounds by just using these kinds of injections. Nothing else. There's no biologics that are put in there. It's just straight up local wound care. So you know that these stromal injections are actually what's going on and helping. Here are the ones with closed 100%, but here are the ones, I mean, I'm taking it from here to here. That's pretty good too as well. So very, very exciting that there are new technologies. It's not just building on what we've had before. Some of these things are brand new it's great. It's just another tool in armamentarium to help these very, very, very difficult patients to heal. And there is a reason why Wayne let me go first. I'm actually playing a gig right after this. So I am missing sound check. But thank you for letting me do this, and I'm going to be able to go there. All right. Thanks a lot, everybody. Appreciate it. Thank you.